Thank you everyone for joining this third FARO-Varian webinar on breast cancer newer advances. My name is Vishal Bhatia and I lead the clinical marketing for Varian for the Asia Pacific region. I would be moderating this session today. Before starting the webinar, I on behalf of Varian would like to thank FARO chair bearers and FARO Education and Training Committee for giving us the opportunity to jointly host this webinar along with FARO. We would also like to extend our special appreciation to FARO Secretary General Dr. YASUSHI NAGATA and our esteemed speakers today, Dr. KITWADEE and Dr. SUSHIL BERIWAL and Dr. IMRT. We will start with the opening address video message from Dr. YASUSHI. As Dr. IMRT told, Dr. Nagata is not able to attend today's webinar. Dr. Nagata needs no introduction. He is the professor and head of the Department of Radiation Oncology, Graduate School of Medicine at Hiroshima University. He has 350 plus published articles and 100 plus speaker invitations from national and international conferences. So here is the video message from Dr. Nagata.
Hello everyone, my name is YASUSHI NAGATA, and I am Secretary General of the Federation of Asian Organizations for Radiation Oncology, FARO. I am also a member of the Board of Directors of the Japanese Society for Radiation Oncology, JSTI, and the Chair and Professor of the Department of Radiation Oncology, Hiroshima University, and the Director of the Hiroshima Cancer High Precision Radiotherapy Center. Thank you very much for participating in the third FARO-Varian webinar today. Today's topic is breast cancer, new advances. Since the COVID-19 pandemic, FARO have been holding a variety of Zoom webinars, including FARO-Varian webinars, for more people attending from all over the Asian countries. We feel that the demand for FARO webinars is expanding even now that the COVID-19 is coming to an end. FARO was established to build strong relationships among the national radiation oncology societies across Asia with the firm resolution to improve healthcare for patients and cooperating with member societies in research, education, and clinical practice of radiation therapy. FARO currently consists of the national organization from 14 Asian countries and 2 corporate members, including Varian Medical Systems. Currently, the International Radiation Oncology Network, IRON, is under planning through the IAEA, and FARO is set to be a member of the IRON to further promote radiotherapy even across the world. Next FARO meeting is scheduled between October 11th and 13th at Seoul, Korea in 2023, next year. I hope everyone to join this meeting on site next year. We hope that today's webinar will help you to learn more about advances in breast radiotherapy and the management of Axilla in Sentinel node. Breast cancer is most common in the radiotherapy department in Japan and is around 25% of whole patients. Breast conserving therapy, including radiotherapy, and post-operative radiotherapy after mastectomy are very common. Recently, a clinical trial of radiotherapy after induction chemotherapy avoiding surgery for HER2-positive breast cancer started under JCOV 1806 in Japan. The significance of radiotherapy for breast cancer is apparently increasing. In closing, I would like to express my sincere gratitude to the speakers for today and everyone involved in organizing this webinar. Thank you very much for joining us today.
That was the message from Dr. Nagata. Now I'll introduce our speakers for today's session. So our first speaker is Dr. KITWADEE SAKSORNCHAI. Dr. KITWADEE is working as a consultant in radiation oncology at King Chulalongkorn Memorial Hospital and as an assistant professor at Chulalongkorn University, Thailand. She has 20 plus published research articles in reputed journals and has participated in various national and international radiation oncology symposiums. She is an active member of Committee of Thai Breast Disease Society and Committee of Thai Society of Therapeutics, Radiology and Oncology. Dr. KITWADEE has keen interest in advancing the cause of breast radiotherapy with innovative techniques, and we are lucky to have her as our speaker today. Dr. KITWADEE will be presenting on advances in breast RT, IMRT, VMAT, and future considerations, and her session will be followed by the session from Dr. SUSHIL BERIWAL on management of Axilla in Sentinel node era. Dr. SUSHIL BERIWAL is the Vice President of Medical Affairs in Varian and is a leading radiation oncologist and a former medical director in University of Pittsburgh Medical Center System. He is a fellow of both American Society for Radiation Oncology and the American Brachytherapy Society. He has published over 280 plus peer-reviewed articles and has authored 170 plus books, book chapters, and review articles. Spanning his 17-year career in radiation oncology, Dr. BERIWAL has received numerous awards, leadership appointments as a physician, teacher, and researcher. During these sessions, if you have any questions, please use the Q&A box to post those questions, and Dr. KITWADEE and Dr. BERIWAL will address the questions at the end of their respective sessions. So I now formally invite Dr. KITWADEE to start her session.
So now everyone, my slide, great. Yeah, so thank you for your introduction, and thank you FARO and Varian for inviting me to share my experience in breast radiotherapy. So this is my disclosures. And my talk today will involve the introduction of IMRT and VMAT technique and the studies that use inverse planning in breast radiotherapy. And also I'm going to share my experience at my center, King Chulalongkorn Memorial Hospital. So the techniques of breast radiotherapy has evolved, since 1980s, since the radiation plan was done with plain X-ray, that's 2D planning, and then followed by CT-based 3D planning. And now it's the era of using modulated radiotherapy. So basically, when we talk about modulated radiotherapy, there are two types of modulated radiotherapy. So forward IMRT and inverse IMRT. So forward IMRT such as fill-in-field or electronic compensator techniques. And this is just a simplified version of IMRT, and only few segments of the treatment field are manually optimized. And maybe I would classify this kind of forward IMRT as part of 3D CRT in this era. And for inverse IMRT, it's it's more complex process that we're going to talk about it later. So this is an example, a case of fill-in-field technique, and many studies comparing of fill-in-field techniques with tangential field radiation. And they found out that with fill-in-field techniques, it gives you better dose homogeneity index, and also better reduce in maximum dose of PTV when comparing with tangential field radiation. This is another type of forward IMRT, as you all know, electronic compensator technique. So this is one of the radiation technique that they modulated dose by using dynamic MLCs. and with Fluence editor, which is also flexible tools that we use to modulate the optimization distribution by painting the Fluence map. And this is distribution comparing. On the right side, it's we use electronic compensator, and on the left side, just tangential field radiation. And you can see that distribution is better when we use e-compensator. So this is a study comparing of using forward IMRT, either field in field or electronic compensator. So when we use field in field techniques, when we try to reduce the high dose region, sometimes it results in reduce the volume of the PTV that receive the dose greater than 95% of the prescription dose. So when comparing between e-compensator and fill-in-fill techniques, you can see that with e-compensator, it reduced the volume of the PTV that receive the greater dose than 107% of the prescription dose, and increase the PTV volume that receive the dose greater than 95% of the prescription dose. This is a clinical study that I'm comparing of using forward IMRT with tangential field radiation, which is the control arms. So there are studies from the UK, Dr. Donovan, Mukesh, and also from Canada study. So you can see that the results of using forward IMRT reduce more of moist desquamation and reduce late breast toxicity, and that results in improved cosmetic results in breast cancer. So how about inverse planning? It can be either IMRT or VMAT. And these are 4 scenarios that there are clinical and dosimetric study that use inverse planning. So the first is whole breast only radiation. The second, regional lymph node radiation. And the third with partial breast radiation and simultaneous integrated boost. So let's start with the first scenario of the whole breast only radiation. So this is this dosimetric study from our center. So at that time, we compare between using 3D just tangential field radiation and forward IMRT and inverse planning. So homogeneity index, conformity index was better when we use an inverse or forward IMRT than with the 3D CRT. And this is a very large trial, a prospective and randomized trials from Korea, which included almost 700 patients with early breast cancer patients. And patients were randomized either using 3D CRT or IMRT with SIB. The median follow-up time was 36 months, and there was no statistically significance in local regional recurrence-free survival, regional free survival, and overall survival between 2 arms. And this is their treatment plannings. 2 pictures on the left side, it's in the 3D CRT, tangential field with sequential boost. And on the right side, it's inverse planning with SIB. So when comparing of toxicity, and you can see that the IMRT planning, inverse planning provide better in terms of toxicity. And the dermatitis greater than grade 2 was lower in IMRT than in 3D CRT. And for the lung and heart dose was lower again in IMRT plan than in 3D CRT. Another clinical study from Michigan, this is also a very large prospective multi-center trial, included 5,000 patients, with patients did 3D CRT and forward and inverse IMRT. So this study tried to focus and looking at acute toxicity of those techniques. And for multivariate analysis, in terms of acute toxicity, the odd ratios of using inverse IMRT was 0.6 in conventional dose radiation and was 0.4 in hypofraction radiation. So the toxicity was less than using 3D CRT. So from this table, grade 3 radiation dermatitis treatment breaks due to toxicity was lower, either forward or IMRT or inverse planning when compared to 3D CRT and both hypofraction and conventional radiation. So those are the studies that use inverse planning in whole breast radiation only. But how about if we want to use inverse planning in the volume that we want to include regional lymph node radiation? And most of paper, they include IMN as well. So this is a study from the UK, and a variety of plans were made. There are 3D CRT, just tangential field radiation, VMAT, proton, thermal, and with and without breast management. So the best plan for coverage PTV and IMN was VMAT with DIBH and proton, either DIBH or free breathing. And the mean heart dose was very low when you use DIBH with your technique, either with 3D CRT or VMAT or thermal, but not with proton. And another study from Dr. Jaxi, and the volume was the same as the previous one, which included breast and chest wall, regional lymph nodes, including supraclavicular, infraclavicular, and internal memory nodes, intercostal space 1 to 3. And patients were randomized either 3D CRT, forward IMRT, free breathing, and inverse planning with the IBH. And we all know that the lung and heart dose was lower in the IBH arm in IMRT. For example, left ventricle of V5 in 3D arm was 15% and 5% in IMRT DIBH arm. And I think the lower dose would be because of the technique of DIBH. So how about using inverse IMRT in partial breast radiation? And there are many studies doing partial breast radiation and many dose fractionations as shown here. So there are studies from Import Low, Rapid Try, and SSBP B39. So these 3 studies, they use fill and fill technique forward IMRT. But for foreign study, they use inverse IMRT plan. How about the studies in using inverse IMRT in simultaneous integrated boost? So basically, the studies such as Import High, IMRT MC2, and ARO. Randomized studies of using sequential boost and SIB. And you can see that the techniques that used in the study, either forward or inverse IMRT. This study published that the number of people that use inverse IMRT in SIB planning has been increased after the publication of Import High study. There are 2 studies that we're waiting for the results of RTOG 1005 and HypoSIB. And both 2 studies, the techniques also involved forward and inverse IMRT in the planning treatment. So as I mentioned, inverse IMRT, it's a more complex process. We have to start from radiation oncologists have to control the volume that we want to radiate, the organ at risk, and then we have to prescribe dose and dose constraints, and then medical physicist will decide the number of beams and beams angles, and then do optimization. Doctor will approve the plan, and then with the QA process and IGRT at treatment room. So I think the advantage of inverse planning, its ability to reduce higher dose area and improve dose conformity and homogeneity. But invoice planning also associated with increased staff workloads, since generating the plans, QA process, and IGRT. So at our center, King Chulalongkorn Memorial Hospital, we have started using invoice planning in breast radiotherapy since 2005, but we rarely use this technique at that time because we have no experience. But the number of VMAT or invoice planning used in breast radiation has been increased every year. And you can see that the number of patients that we use is a little bit high for this year. And I think this is because we are running the clinical study that using ultra hypofraction in breast cancer, that we tend to include patients with nodal radiation and also breast with SIB. So indications of using invoice planning in our center are like the treatment plan that cannot be achieved by 3D CRT, and we think that invoice planning might improve therapeutic ratio. Or the patients who need comprehensive regional node radiation targeting, or patients with complex anatomy, such as pectus excavatum. So at simulation room, CT simulation, patients are in the supine position with straight face, with both arms over the head, and they will be immobilized using Vaglock cushion with wing board and knee support. And then we have found out that reproducibility of arm and shoulder are very important, and it's better when we use Vaglock cushion than using breast board. So for contouring guidelines, there are many guidelines, RTOG, RADCOM, ASTRO guidelines, but because we usually perform inverse planning in locally advanced breast disease, because we tend to cover all regional lymph nodes. So this is a study suggesting that we should follow RTOG and RADCOM guidelines when we want to radiation to patients with high and very high regional risk. But there are something that I like to point out, like for middle border of supraclavicular field in RTOG and RADCOM, they include internal carotid artery. But from my practice, sometimes I contour at the lateral of the internal carotid artery, which is around here, because there are data suggesting that there was very rare recurrence at medial to internal carotid artery. And that we contour at the lateral of the internal carotid artery, and that will reduce doses to thyroid and esophagus. For posterior border of breast and chest wall, as it's uncommon for recurrence at intercostal muscle or ribs, so I would contour at the anterior rib structure to the skin, subcutaneous tissue, and pec muscle. But I would contour all structures, especially in patients with T4 or inflammatory breast cancer, or patients with very thin chest wall. But dose prescription, we do both conventional and hypofraction radiotherapy. But in the patients that IMRT will be involved in the target, most of the doctors here prefer to use conventional dose radiation, because the data of involved IMN in the volume, mostly they've done it with conventional dose radiation, 50 grays in 25 fractions. For dose constraints, so there are dose constraints for whole breast, chest wall, or adding regional node radiation. And this is the conventional radiation dose constraint. And for hypofraction radiation for whole breast only, we follow RTOG 1005. For dose constraint with adding regional node radiation, like with conventional radiation dose, we follow those constraints from Mario Sloan Kettering Cancer Center. And for hypofraction, we follow European Institute of Oncology. So for planning, like IMRT, so the number of gantry angles will be optimized for each patient and generally range between 5 and 7 beams. For the left breast, the medical physicists always use 100 to 350 degrees. And for right breast angles ranges from 240 to 55 degrees. And the plans will be delivered using dynamic MLCs. For VMAT, we use 4 partial arcs at the angles for the right breast, 440 to 50 degrees, and left breast 135 to 310 degrees. And when consider using either VMAT or IMRT in inverse planning, we prefer to use VMAT because it's shorter period of time, especially in patients with DIBH. And with Halcyon, the treatment time would be faster. So we prefer VMAT over IMRT. Regarding IGRT, we do cone beam CT on the first, second, and the third day of the week, and then weekly. And other fractions we use EPID. And we also have vision RT, for patients with DIBH. When we do cone beam CT or EPID, we follow our body guidelines. For example, if the shift is greater than 1 centimeter, we're going to notify doctors, and maybe re-CT simulation would require. Or the shift between 6 to 10 millimeters, we're going to perform cone beam CT, apply shift, and then repeat cone beam CT again. But for the shift less than 5 millimeters, we're going to apply shift and then treat. So for ultra hypofraction radiotherapy, as you all know, there are 2 studies right now, FAST trial and fast forward trial. So for fast trial, this study tasting of 1 fraction once a week for 5 weeks. And then for fast forward trial, they taste of 1 fraction Monday to Friday. So just finished within 1 week. And patients in these 2 studies were mainly early breast cancer. So the recommendation from European Society for Radiotherapy and Oncology, they recommend that ultra hypofraction can be offered for non-nodal breast or chest wall without reconstruction. And for NCCN guidelines, ultrafraction may be considered in selected patients, like patients older than 50 years old, breast conserving surgery, and very early breast cancer like DCIS or T1, T2, N0, M0. But in NCCN guideline, they prefer to use FAR trial regimen because it has a longer follow-up than fast forward trial. So as we would like to introduce proton in ultra hypofraction radiation in post-mastectomy, so we think that it might be necessary to do a dosimetric study comparing between dose parameter and organ-at-risk dose between photon and proton. So this is our study just published this year. It's a dosimetric study comparing of photon and proton in post-mastectomy radiation, and we use ultra hypofraction regimen. And the VMAT plans, we use 4 arcs at the angles of the right breast 240 to 50 degrees, and for left breast 135 to 310 degrees. And for proton, for IMPT plans, we use 2 fields. an AP field, and an anterior oblique fields with the gantry ranges from 30 to 45 degrees. So for almost all our parameter was better when we use IMPT than VMAT, except ipsilateral lung dose and mean heart dose for left breast, left chest wall with regional lymph nodes. So the heart dose is lower, but not significant. But for other conditions like left or right chest wall only, or right chest wall with regional nodes, mean heart dose was significantly lower in IMPT than VMAT. So although the DVH in proton looks better than photon in our study, but it doesn't mean that proton ultra hypofraction in PMRT can become the standard of care in our center. So we think that it would be necessary to run a clinical trial that will address that the benefit or the advantage of dosimetric evaluation that we have done will translate into the clinical benefit in clinical studies. So this is the studies that we are running. We enroll patients with T1 to 3, M0 to 3, M0. So it's non-metastatic breast cancer, and randomized either proton or photon, and using ultra hypofraction of 26 grays for 5 fractions consecutive day. And patients who require breast boost will do SIB or 31 gray in 5 fractions. Primary outcome, we would like to look at acute skin toxicities. And for secondary outcome, we looking at local regional control, cosmetic outcome, and late toxicities. So we just opened this study last year. So the concern of using inverse planning, as you know that with inverse planning, the low dose area outside the target volume increases. And the second malignancy, especially contralateral breast cancer, is one of the concern. So when we're looking back at the data of the dosimetric study, we have found that this is a study from 2021. They compare of the dose of the planning 3D CRT, VMAT, and proton. And they found out that the mean dose of contralateral breast was very low in those treatment plannings. And this is the differences between the mean contralateral breast dose, differences between the techniques. And we found out that the difference of like VMAT, either FEBREATHE or DIBH with 3D was 1 gray. Another study from UK, and this table also indicates the differences between the mean right breast dose of VMAT technique and white angel field radiation. And they are in the white boxes, which means it's not statistically significant difference between those techniques like VMAT and white angel field radiation. This is the clinical study. I mean, they follow up patients who is the childhood cancer survivors. They study from Memorial Sloan Kettering Cancer Center. These 325 patients received inverse planning treatment, and the median follow-up time was 11 years. Median time from IMRT to solid secondary malignancy was 11 years. 10 cumulative incidence was 1.8%, and 15-year cumulative incidence was 3.5%. And the important thing is that this paper, they found out that many solid secondary malignancy after inverse planning develop in high dose region, not low dose region, as we understand. So in summary, I do agree with the recommendation from ASTRO guidelines published 2014 that if it's just whole breast radiation after breast conserving surgery only, we shouldn't do inverse planning routinely, but we'll use inverse planning in those circumstances that I have mentioned. Yeah, so that's all today.
Thank you, Dr. KITWADEE, for the excellent talk and insights into the advances happening in breast cancer field and sharing the experience from your own center. We have a few questions that have come up, so I'll just go through them one by one. So, Dr. KITWADEE, first question is, were there any challenges when you started the IMRT or VMAT breast practice at the first or at the start?
So the challenges that we have encountered when we first use IMRT and VMAT, so because IMRT and VMAT is a very complex process, like from radiation oncologists, we have to consider which guidelines that we are going to use for contouring, because at the first time, different doctors, different guidelines. So we have to decide which guidelines that we are going to follow. And then for medical physicists, I think we have a lot of training for them in terms of testing, commissioning of the new equipment, and also how they're gonna calculate, the dose, how to do optimization. And, when we comparing of the dosimetric evaluation, the DVH that we have done the plan many years before and now, we have known that our medical physicists are more experienced, and the DVH and all the parameters looks better. So, so this is for medical physicists. And I think in terms of radiation technologists, I mean, the challenges that might be in the CT. At the simulation room, when we first very used to 3D CRT, and we use breastboard in the simulation. But when we apply this for inverse planning, when we do cone beam CT, we found out that the arm and position, arm and shoulder position was a little bit, not correct for each day. So when we try to use backlog and wingboard, I think the position and reproducibility, it's better. So this is what we have learned. Yeah.
Thank you, Dr. KITWADEE. And a related question to this one, apart from the things that you have highlighted, what would be your advice to centers who want to start IMRT or VMAT best practice and upgrade from 3D CRT? What more resources would be required for them?
Oh, so I think the important thing is the training system, like training, as I mentioned, training radiation oncologists to make a contour, and also the medical physicists, how to do optimization, something, the QA process like that. And also radiation oncologists in terms of how to mold the backlog, how to set the position.
Thank you, Dr. KITWADEE. And at the end, you mentioned the FAST trial and the fast forward trial. A related question, how can the penetration of fast forward regime or short course fractionation in breast cancer increase in Southeast Asian countries?
So after the publication of fast and fast forward trial, I think, for whole breast or chest wall only radiation, ultra hypofraction becomes the standard of care, I think, in the UK. And I would think that maybe in 2 to 3 years, it would become standard of care in, in radiation in breast, chest wall, and regional node radiation as well. Maybe after fast forward trial, we'll publish the node sub-study. But in my opinion, as for now, I would comfortable to use ultra hypofraction in breast cancer, in early breast cancer, without node involvement and without reconstruction. I would prefer to use this, in patients that we really want to finish the treatment time very quickly, like especially in the past COVID-19 pandemic, that this is also an option. Excuse me, I can't hear you.
I was on mute. So I was saying that was our last question. Now we can move over to our second session with Dr. Sushil BERIWAL. And thank you, Dr. KITWADEE, for the insightful presentation as well as answering these questions.
Thank you, Dr. KITWADEE, for excellent talk. That makes my job a bit more easier now. So what I'm going to talk about is, like as we all know that breast cancer care has changed. We all do de-escalated therapy, and sentinel lymph node biopsy has become standard of care. So, but for us radiation oncologists, the questionable or the harder part is what to do in women who only have sentinel lymph node biopsy done. How to address that situation in terms of what volume to treat and what area to treat. And there is a lot of uncertainty in this regard. What I'm going to cover is what I do in our practice based on the literature, which I'm going to discuss. And the literature is all over the place. So there are multiple ways of doing the same thing. What I'm going to discuss is not the only way, but I'll discuss my rationale in why and how we do things. So these are my disclosures. So we know that axillary management has transitioned. It used to be lymph node dissection for all. Then sentinel lymph node biopsy came into place, which showed that for clinically N0 disease, it has very high negative predictive value and less morbidity, and that became standard of care. Initially, anybody who had sentinel lymph node biopsy positive used to undergo dissection. Then multiple clinical trials came out, and I'll discuss some of them, which showed that for women with 1 or 2 positive node, we don't need dissection. So dissection became obsolete for women with 1 or 2 positive node. As we got good outcome data for upfront sentinel lymph node biopsy, then the second question came up, can we do sentinel lymph node biopsy after neoadjuvant chemotherapy? And the study showed that if you're clinically N0, your negative predictive value is same. But what about if you're clinically positive? And then in that regard, a couple of trials came out which showed that if you are clinically positive and become negative, sentinel lymph node biopsy can be done with some caveat, and I'll discuss some studies with this regard. And last but not the least, if you have neoadjuvant chemotherapy and the nodes are still positive even after chemotherapy, what to do with it? So the first is why sentinel lymph node biopsy, and as you all know that these are 4 seminal prospective randomized trial which compared sentinel lymph node biopsy to axillary lymph node dissection for early stage breast cancer. What they showed that the negative predictive value for sentinel lymph node was as good as lymph node dissection, but the added advantage was less lymphedema, less affected range of motion, less shoulder dysfunction, less numbness. So with less side effect in women with breast cancer and similar negative predictive value, it became standard of care. But it opened up a new type of nodal burden disease like isolated tumor cell, micromets and macromets, which was not available when we were doing dissection only. And that's where some of the uncertainty comes in. So what do we do when somebody has sentinel lymph node biopsy done? And we know that if patient has node negative disease, then it has high negative predictive value and we don't need to do anything. But what about if somebody has 1 or 2 positive node? And in that regard, there are at least 7 or 8 trials, and I'll discuss some of them with different interpretation. So these are the 4 prospective randomized trials which compared sentinel lymph node biopsy to axillary lymph node dissection with no additional field of radiation. That means they did not want physician to change the field of radiation. These are almost all patients with lumpectomy. They would get whole breast radiation therapy. When you do whole breast radiation therapy, part of the axilla may get treated, but they did not want physician to modify the field. So the idea was if somebody has positive node, we don't do anything other than whole breast, what happens to the axillary recurrence rate? If you look at the data, there was no difference in axillary recurrence rate and no difference in disease-free survival, whether they got lymph node dissection or not. Now, if you look at these 4 studies, the first 2 studies were mainly for micromets, so had low likelihood of finding more disease. The AKSOG included both micromets and macromets, and this is the most recent one, which included only macromets, 1 or 2 macromets. And then this is the only one which, even after macromets, had some patient with mastectomy. So that means there are a small subset of patients who didn't have radiation therapy. But interpretation is same, no difference in exit recurrence, no difference in disease-free survival, letting us know that in women who have 1 or 2 positive nodes, if you do whole breast radiation therapy, the recurrence risk in the axilla is low. But the study got confounded by the fact that the largest of the study was Z11, even though the physicians were not supposed to modify the field, they did. When they got radiation portal information in a subset of women who were treated in Z11, they found that about 81% were treated with tangents only, but among those who got tangent, only half got high tangent. That means they have targeted level 1 and 2 node, which is the site of additional disease. And about 19% also got third field. So even though the study was designed, no additional field, it's hard to interpret what is the effect of these fields because some got high tangent, some got 3 field. So one thing we can conclude that we do not need dissection, but we don't know what volume to treat. Like this is an example of a tangent only. You can see when you do tangent only, part of level 1 and part of level 2 gets treated. And when you do high tangent, most than 1 and 2 gets treated. So these are the site of additional disease in somebody with center for biopsy positive. Some of it is covered in tangent only, but most of it is covered in high tangent. This is an example of tangent only. Now, at the same time, the 4th prospective study I talked to you about, which we're talking about no change in radiation therapy. There are 3 additional trials, and I'll discuss the first 2, which are the modern one, which basically did the same thing like Z11, that patients with 1 or 2 positive nodes, they were randomized to axillary dissection, but this experimental arm was axillary radiation therapy. So they did treat level 1, 2, 3, and supraclav. So unlike Synodar 1, unlike Z11, unlike IBCSG, they added third field. Again, these trials, if you look at the risk of finding additional node, is 33 to 38%. No difference in exit recurrence, no difference in disease-free survival, and as expected, significant difference in lymphedema. So in the radiation arm, the lymphedema was much lower than surgery. So again, the trial showing that in 1 or 2 positive node, you don't need surgery. But if you combine all these 7 trials, one thing we can easily conclude that in women with 1 or 2 positive nodes, either micromets or macromets, they don't need additional surgery. But we are not sure what volume to treat because in Synodar 1, it was breast only. In Z11, it was mixed match of everything. And in Amoros and Otosar, it was comprehensive regional load. If any one of them had impact in outcome, it's hard to delineate. This is an example of regional node. Some of it was shown by the previous speaker, showing level 1, 2, 3, supraclav and upper IM node. The other important question comes up is in the first 4 clinical trial, which were no additional treatment, almost all had lumpectomy done. So almost all had whole breast radiation therapy. And when you do whole breast radiation therapy, part of level 1 and 2 gets treated. But what happens if they have mastectomy done? What do we do when they have mastectomy done? So if they have mastectomy and micromets, do we really need to do anything? Can we ignore the finding or do we need to add radiation therapy because patient did not have dissection? Because even with micromets, the risk of finding additional disease is 12 or 13%. In IBCSG and ATRAM, only a small subset of patients had mastectomy done without radiation, and none of them had recurrence. In a largest retrospective analysis from MSK, where about 300 plus patients had low volume disease, including ITC and micromets, a significant number of them did not have dissection done, and they did not even have post-mastectomy radiation therapy done. And they found that whether they had dissection or not, and whether they had radiation or not, the risk of axillary or chest wall recurrence was very low, 2 or 3%. So the conclusion from this study was, if you have T1, T2 disease with N1 mic or N1 ITC, you don't need post-mastectomy radiation therapy routinely, just because patient did not have dissection done. Now, switching gear, what do we do after neoadjuvant chemotherapy? What is the data after neoadjuvant chemotherapy for axillary management? So, as I was mentioning, that if somebody is clinically node positive and becomes clinically node negative, and they undergo Sentinel for biopsy, if the node is negative, in the 2 clinical trials, the AKSOG and Sentinel, when they looked at negative predictive value, the negative predictive value was maybe 87%. It did not meet the threshold of more than 90%. So if you're a purist, you would say that if somebody is clinically N0, becomes clinically N, and clinically N1 becomes clinically N0, I would avoid central biopsy because of the less negative predictive value than design point. But when they went back and looked at the data, if somebody had dual tracer injected and at least more than 2 nodes were taken out, the negative predictive value was 95% plus. And a third factor was added: if the biopsy proven node was clipped and at the time of central biopsy it was taken out, that also improves the negative predictive value. So despite the data, it's very commonly done in practice where women who have node positive disease, the node normalizes after chemotherapy. Central biopsy is done following all the 3 procedures we are talking about: more than 2 nodes, dual tracer, and clipping the node. So, and this is the conglomerate of Sentinel and AKSOG, that even though the false negative rate was more than 10%, but it was below 10% if 3 or so more than 2 nodes, use of dual tracer, and also marking the clip, which is commonly done in our practice. So what happens when you have clinically N1 disease and it becomes and you do become N0? So this is T1, T2, N0 disease. Whether we should add regional node radiation therapy or not, the question is being answered by B51, where women who have N1 and become N0, they are randomized to regional node versus no regional node. And outside clinical trial, I don't treat most of these women except if they have triple negative breast cancer or other adverse factor. If they're clinical N1 and you do a central biopsy and it's still pathological N1, the standard of care is to do dissection followed by regional node. The ongoing alliance trial is trying to see whether we can skip dissection and just do regional node. If they're clinically N2, then it's stage 3 disease, irrespective of response, all of them will get regional node. So 3 scenario: N1 becoming N0 is uncertain. N1 persisting N1, they need dissection followed by regional node. N2 becoming N0, they need dissection followed by regional node radiation therapy, irrespective of the response. So this is the B51, which is closed clinical trial where node positive who become node negative. If they have lumpectomy, they are randomized to with and without regional node. If they had mastectomy, then they are randomized to with and without regional node, or with and without post-mastectomy radiation. And the alliance trial, which is again concluded, is if they have persistent positive node, they undergo dissection followed by regional node radiation therapy. The trial is trying to see whether we can skip dissection and just go to regional node. Now, it's interesting that these alliance trial allows micromets and macromets, but if you have ITC post chemo, alliance doesn't allow it. Alliance considered as a node negative, while B51 also considered as node negative. But in true sense, is ITC after chemotherapy truly a node negative disease? And I'll discuss some data in this regard. But before we go on to the ITC part of it, this is our own data where women who had persistent positive node but declined lymphodissection for concern about lymphedema or other factor. So we looked at what was the regional control rate in women who had dissection versus no dissection for persistent positive node. And we found that there was no difference in outcome in terms of regional control, in terms of disease-free survival and overall survival, but not unexpectedly, the risk of lymphedema was almost 3 times more if they had dissection done. So in carefully selected patient who declined dissection and then discussing pros and cons of the data, you can discuss about regional node radiation therapy in lieu of surgery. But the standard of care is still to do surgery, but understanding the fact that there are women who are concerned about lymphedema risk and may or may not go for the dissection. So what do you do when you have, so we talked about you have T1, T2 disease and mastectomy done and have micromets or ITC. The data suggests that the risk of local relapse without any additional treatment to the axilla is low and you can skip anything. But what about if you have T1, T2 disease and macromets and 1 or 2 positive node? Now, the Astro panel recognizes that some of these women would, some of the surgeons would omit lymphodissection. So what do we do in practice is if somebody has high risk factor, like T2 disease, premenopausal, high grade, triple negative, LVSI, high oncotype, we know that these women will need post-mastectomy radiation therapy. And we know from MROs that regional node gives equivalent regional control rate in comparison to surgery for T1, T2 disease after mastectomy. So we, instead of dissection, we just do post-mastectomy radiation. But if they don't meet the criteria, then you discuss with the patient pros and cons of dissection versus radiation, and I'll discuss some of it. So what about ITC after neoadjuvant chemotherapy? If you look at the SN-FNAC trial, where they said, what is the risk of finding additional disease who have ITC after chemotherapy? Look at the risk of finding additional disease is as high as micromets, as high as macromets. What it is telling you is that ITC post-chemotherapy is not the same disease, because for women who have upfront ITC positive only, the risk of finding additional disease is few percentage. But ITC post-chemo is behaving like node positive disease. So we need to be very cautious about not doing anything for ITC post-chemo and treating them like N0 disease, which may or may not be the right thing to do just because of risk of additional disease. In another study from MSK, where they looked at what is the risk of finding additional disease in ITC, micromets and macromets, you can see even for ITC, the risk of finding additional disease was about 17%, even though it's a small number. Just letting you know that we need to be very cautious about it. In our own practice, we treat ITC post-chemotherapy like node-positive disease and offer regional node radiation therapy, like micromets or macromets. So what do you understand by the term regional node radiation therapy? There is resurgence of regional node radiation therapy because of the recent data which have come out from MA20, EORTC, Danish, and more recently from the Korean randomized trial. What regional node radiation therapy means: undissected axilla, supraclav, which is basically the level 4 medial neck node, and upper IM node. So if you look at MA20, which was all women who had lumpectomy and lymphodissection done, majority had N1 disease, about small percentage had node negative disease. They were randomized to whole breast with and without regional node, which included internal memory, supraclav, and axilla. The IM node were treated with either modified tangent beam or mixed photon electron beam and to the first 3 intercostal space. And the fractionation used in those trials was conventional fractionation. If you look at the data, there was very small difference in regional recurrence rate, 2.5% versus 0.5%. You may say that this is a very small difference in regional recurrence rate for regional nodal radiation therapy, and regional node may or may not be of much benefit. But look at the impact. This small difference in regional recurrence rate translated into 4% improvement in distant recurrence and about 5% improvement in disease-free survival, probably showing that regional recurrence may not be the best endpoint. Along with that, the decrease in distant mets and improvement in breast cancer mortality is more important endpoint. So showing that the impact of regional node is indirectly decreasing the risk of distant mets. There is no difference in overall survival in the study. On subset analysis, the maximal benefit was seen in triple negative, where the disease-free survival was almost 10% different. As expected, there is more side effect, but they were all minimal, like pneumonitis and radiation, like grade 3 pneumonitis, no patient had it. The dermatitis went up because of a larger volume of disease, but they were only mainly grade 1 and grade 2. The lymphedema risk was again slightly went up as expected because of regional node from 4.5% to 8.5%, but overall the treatment was well tolerated. At the same time, when MA20 did regional node versus no regional node, EORTC also did a similar trial, a much larger trial. The two major differences were it had about 25% with mastectomy, and it had higher subset of patients with N0 disease compared to MA20, which had only like 10% or so. And randomization was same, whole breast with and without regional node, or post mastectomy with regional node versus no radiation therapy. IM node was treated in the first 3 intercostal space like MA20, but if it was lower in a quadrant, then all 5 spaces were treated. And again, you can see the difference in regional recurrence rate was very small, 4.2 versus 2.7, but similar difference in disease-free survival and breast cancer mortality, but no difference in overall survival. Probably it was diluted because of the inclusion of more than 40% of the women with N0 disease, where the value of regional node may be debatable. But both the clinical trials showed that when you add regional node radiation therapy, it has small improvement in regional recurrence, but a significantly similar improvement in distant mets, disease-free survival, and breast cancer mortality, but not reaching difference in overall survival. The Danish trial, which is the third clinical trial, which was done, which is not a prospective randomized trial, but a prospective population-based study, where all women with right-sided node-positive breast cancer got IMN, and left-sided, because of concern of heart, were not had IMN treated. The only difference was, since it was right-sided, they treated first 4 intercostal space, again using the same thing like modified tangent or electron-photon match. And in this clinical trial, there was improvement in overall survival, but there is a mismatch probably because it was not true randomization. Improvement in breast cancer mortality and overall survival. And the benefit was mainly seen in 4+ positive node or medial or central location. In 1 to 3 positive node, there was a trend, but no difference and no benefit for N0 disease. And probably that explains why in the EORTC, we did not see overall survival difference, because a significant percentage were N0 disease. The last but not the least is the Korean study, which is different from the first 3 trials. In the Korean trial, they were looking at whether IMN treatment helps or not. So all got regional node, but 50% got with IMN, 50% without IMN. Unlike the Danish trial, which was population-based cohort, this was a true randomized trial. The trial, the way it was designed, did not see any difference in disease-free survival, as you can see. But in unplanned subset analysis, very similar to what was seen in the Danish population-based study, if you had medial or central located tumor where the likelihood of IMN involvement is high, there was 10% improvement in disease-free survival. Again, hypothesis generating, but not conclusive. So what do we do in practice? So if somebody had sentinel for biopsy done and has micromets and has lumpectomy done, then we don't do lymphodissection. We do whole breast radiation therapy with high tangent. But these patients may be suitable for whole breast alone, and partial breast may be a reasonable alternative. But in my practice, I prefer the first approach, where I do whole breast with high tangent, including 1 and 2. If they have mastectomy done and have T1, T2 disease for micromets, we don't do any dissection and no radiation. The only few times when I consider radiation therapies, if they have triple negative disease, are many adverse factors, but they are infrequent. What do we do if they have macromets? If they have macromets and 1 or 2 positive node, if they have lumpectomy done, then I would at least treat whole breast with level 1, level 2 axilla in the tangential beam. But if they have adverse factor like premenopausal, extranodal extension, aggressive phenotype, LVSI, or high genomic score, then I would add regional node radiation therapy. There is an ongoing Canadian study which is looking at women with low genomic score with and without regional node to see whether regional node helps or not. If they have macromets and mastectomy done, and if they have adverse factor like these, then I would not do any dissection, just do post-mastectomy radiation. But if they have no adverse factor, then you discuss pros and cons. If they undergo dissection, then there is high risk of lymphedema. If they undergo radiation and reconstruction, high impact on reconstruction. So it's an informed decision making with the patient in terms of pros and cons of the treatment. But currently, all macromets get something done to the axilla. In Synodar 1, there was a small subset who didn't have anything done, but that's a small subset. There are ongoing studies which are looking at, can we skip doing anything to the axilla for macromets? That means no surgery and no radiation. They're ongoing, but outside clinical trial, everybody with macromets does get something done to the axilla. Most of the time it's radiation, but sometimes it's surgery if there is potential effect of impact on reconstruction. Sometimes if they have lack of adverse factor and they do not want impact on reconstruction, one can consider treating axillary lymph node only to avoid effect on reconstruction. I have not done it, but that was allowed in the AMAROS trial. If they have 3 or more positive node, then technically they undergo dissection followed by regional node radiation therapy. What do we do if they have neoadjuvant chemotherapy and sentinel for biopsy? So if it is positive for micromets and macromets, the standard is to do dissection followed by regional node radiation therapy. But if the patient declines dissection, then we do comprehensive regional node. There is limited data. I just showed one of my series, but the number of series are very few. If they have ITC after chemo, we do comprehensive regional node radiation therapy without dissection. We treat them like node positive disease. But if they are node negative after chemotherapy, if they're node positive, become node negative, the value of regional node is debatable. Some treat all, I treat minority, including all with triple negative disease and all with upfront stage 3 disease. But again, it's a matter of B51 study. We, in our own network, standardize the way we treat this sentinel for biopsy women positive patient because we found a lot of variation. So when I standardized it, after standardization, we found that there was significant improvement in the consistency of treating. Like, for example, like after the pathway changes, we found that a lot more women were treated with modified tangents or third field compared to before the pathway, when a lot of women did not have anything done to the axilla, irrespective of their micromets or macromets. So this has changed in our own practice based on the standardization through the pathway. For radiation technique, I will not go into detail, as previous speaker talked about. It could be partially wide tangent. It could be deep inspiration breath hold, but I just want to talk about something with deep inspiration breath hold. So deep inspiration breath hold, we not only use for left-sided breast cancer, we also use for right-sided breast cancer when we do regional load. Because for left-sided breast cancer, it decreases heart dose and lung dose. For right-sided breast cancer, it decreases lung dose and sometimes heart dose if you're treating IMN node, because the denominator goes up. And since a lot of these women are getting immunopembro TDM1 with radiation, whatever I can do to reduce the lung dose, I feel it is beneficial, because in the modern era after neoadjuvant chemotherapy, some get concurrent pembro, some get concurrent TDM1. So my goal is to reduce the risk of pneumonitis and reduce the lung dose. So I use DIBH for both right and lung. Now for the left side breast cancer, it's not only, as I said, lung, it is a heart dose also. Now, when you do DIBH, you need to make sure that the setup is reproducible. In the past, we used to routinely do MV imaging, but now some of our sites, we do what we call a surface guided radiation therapy. It's a non-invasive, non-radiation technique. It helps in decreasing the overall treatment time, minimizing the imaging dose. It can reduce the time required for image registration and need for taking multiple imaging. And it is an excellent tool for setup error and reduce motion management. So what it does, it has got a non-invasive, like 3 high precision camera, which you use at the time of simulation and treatment. The accuracy in the clinical studies is less than 1 millimeter. It takes images, it takes the surface guidance images at 5 to 10 frames per second. It helps to minimize heart and lung dose because of use of DIBH. So it's commonly done with breath hold technique, where you can also manage interfraction motion. People also use for stereotactic for interfraction motion, and some people also use routinely in their clinic for any type of radiation therapy. This is the visual feedback patient sees when they're doing deep inspiration breath hold with surface guidance. It provides patient audio and video feedback so that they can be in that green zone of breathing. That way you can reproduce the setup. So in breast cancer, the study which have compared laser alignment with surface guidance have shown much less setup error with surface guidance than laser alignment. In addition to isocentric positioning, the surface guidance provides chin position, neck position, arm position. It gives you a good guidance and reproducibility of that. And if you have a no action level, you can decrease the exposure by decreasing the number of time you take the imaging. So people are moving from tattoo-free workflow because of the surface guidance. And if you look at this study looking at surface imaging and tattoo setup, you can see the setup error is much less with surface imaging than tattoo for breast, chest, pelvis, and abdomen. So I think there is a significant value proposition for as we become more precise in our treatment, as we use IMRT and VMAT, as we use deep inspiration breath hold, to use something which is faster, reproducible, less exposure, and decreases the error. Now, our previous speaker did talk about fractionation. In our own practice, the conventional fractionation for whole breast is historical value. Almost all women either get 40 and 15 fraction because it has similar local regional control and possibly less acute and chronic effect. The boost could be sequential or SIB, like import higher RTOG, as Dr. KITWADEE spoke about it. We routinely use 26 and 5 for early stage breast cancer in postmenopausal women based on the fast forward data. And we try to follow the fast forward study in the sense that we try to make sure that the dose homogeneity is met. The V105 is less than 5% and there is no V110. So we routinely use that. Also for early stage breast cancer for node negative disease, we also routinely do partial breast radiation therapy, 30 grain 5 fraction like Italian regimen using VMAT and daily IGRT. Initially, we were doing every other day, but based on the recent data, we do every day. So 5 fractions. So in our own clinic, early stage breast cancer postmenopausal, either get partial breast 13-5, and if they're not suitable because of ratio or setup uncertainty or other factor, then they get 26 and 6 and 5 whole breast, like the fast forward. What do we do when we do regional node? I mean, I combine all the published data, the START A and B, the Chinese data, and the most recently the Danish data. The 10 years data doesn't show any difference in local regional recurrence and disease-free survival. There is no difference in chronic effect in the START A and START B, except for one patient who got very high dose per fraction. With 14-15, there is no difference. In the Chinese data, again, there is no difference in acute toxicity, local regional recurrence, or disease-free survival. Most recently, the Danish group presented their data with about 1,200 patients, with comparing 15-25 and 14-15 with SIB boost. 3 years data, no difference in edema, shoulder stiffness. So now that's standard of care there in the Denmark. And that's what we do. So I use hypofractionation in my own practice to almost all patients, except if they're inflammatory breast cancer, they have poor response to chemo, or as Dr. KITWADEE said, if they have residual undissected nodal disease, like IM node or level 3 and supraclamp, then sometimes I prefer conventional fractionation, not because of the effect of fractionation, but more because of effect, like trying to give higher dose. Because 14-15 is equivalent to like 45 gray, 15-25 is equal to 50 gray. And I'm trying to give higher dose to women with inflammatory breast cancer, poor response to chemo, or if they have undissected node, which I'm boosting. So that's the reason for that. Otherwise, all get 14-15. The fast forward regional node radiation therapy trial, the 3 years data showed no difference in arm edema and shoulder stiffness. This was presented at ESTRO. We are waiting 5 years data, which may change the fractionation schedule for this women, but for currently we use 14-15. Somebody asked the question whether we use bolus or not. In the past, we used to routinely use bolus for post-mastectomy, but now we have scaled down based on some of the recent studies which have come out. Unless patient has skin involvement, has inflammatory breast cancer, or very thin chest wall where you are concerned about the dosimetry. But when we use VMAT or IMRT, then we make sure there is an auto flash, or there is flash created for uncertainty and breathing artifact. So this is my last slide. These are some of the ongoing studies which may change how we do things. The SOUND trial is trying to skip central for biopsy for T1 disease. The INSEMA trial, they presented their data at San Antonio, where they're trying to skip central for biopsy for T1, T2 disease. And they presented quality of life data. And it appeared that quality of life was better in no axillary surgery arm, but we need more data in that regard. These are the 2 trials I was talking about, that in women with macromets, they are trying to only do systemic treatment and avoid any kind of axillary lymphodissection or axillary radiation therapy. But up until those trials that come out, we would not know the answer. The reason why we see discrepancy is that involvement and recurrence are not the same. And the reason why they are not same is probably some of it is taken care of by systemic treatment. So this trial is trying to see whether if we do only systemic treatment with nothing to axilla, is the risk of axillary recurrence very similar or not? But outside clinical trial for macromets, we treat all at this point. So with this, I conclude my talk and open the forum for questions. Thank you.
Thank you, Dr. Sushil, for the insightful talk. We have a few questions, so I'll go through them one by one. So first one is, Dr. BERIWAL, how do surgeons take the MSKCC finding of not doing extensive axillary dissection for mastectomy with micromets positive patients?
So as I mentioned before, I just presented MSK data, but the IBCSG also had a small subset of mastectomy. There are 3 other clinical trials which have been, not clinical trial, clinical data which has been published. So there are 5 or 6 studies with micromets for 1 or 2 positive node and mastectomy with no dissection, no radiation. If you look at the axillary recurrence rate, it is between 0 to 5%. So unless patient has T3 disease or triple negative pathology, for routine T1, T2 ER positive breast cancer, the data suggests that we should not do anything to the axilla. And that's what the American College of Surgical guideline also says. Like the guidelines also say for micromets after mastectomy, for T1, T2 ER positive disease or HER2 positive disease, don't do anything to axilla because it doesn't improve regional control. It doesn't improve overall survival. Now, the second question is in a patient with previous lumpectomy and radiation, now with isolated recurrence in the axilla, what do you do after dissection? In these patients with isolated regional nodal recurrence, the course of treatment is definitive. So after dissection, I would focus on treating the undissected axilla, level 3 and supraclav, with and without IM node. But whether I would treat dissected axilla or not, that would depend on other factor, whether there is gross extracapsular extension or inadequate dissection. But I would treat this patient with regional node radiation therapy to maximize local regional control, because these patients are potentially curative.
Sure. Thank you, Dr. Beriwal. One last question from my side. You have told that in US or developed markets where you have been practicing, the adoption of hypofractionation is very high. The usual fractionation is of high, I would say, historical significance. How do you think that the adoption of hypofractionation or ultra hypofractionation for breast cancer can be increased in our region, in vast of Asia?
So, like in US also, it took a lot of time. So, like I presented what I do, but if you look at the practice pattern in the US, for post-lumpectomy, now hypofractionation becomes standard of care. But for regional node, as Dr. KITWADEE presented, it's mixed match. I mean, some people do, others don't. We routinely do it. But I think the education, there are two important components to it. One is to look at the data. The second is how to do it. So two important aspects is, if you look at hypofractionation versus conventional fractionation after lumpectomy, all the data showed similar local regional control. But not only that, it shows less acute toxicity, less chronic toxicity, and better quality of life. And part of the reason is not because of fractionation. That is because of the fact that when you do 14-15, you're giving less dose in comparison to 15-25. Less dose means less side effects. So it is less physical toxicity to the women, less financial toxicity to the women, and better outcome. Now, it is important when we do any kind of fractionation, we emphasize on dose homogeneity, which Dr. KITWADEE also said. So when I do hypofractionation or any fractionation for that purpose, I make sure that V105, volume getting 105% in the breast, is less than 10%. If I do fast forward, then it is less than 5%. And no part of the breast gets 110%. And there is no hot spot in areola and nipple and the inframammary fold. So it's important to maintain dose homogeneity, which is important for skin toxicity. Now, somebody asked a question, in what subset of patient do I radiate internal mammary node? I would radiate for if the disease is, like for all node positive disease, when I do post mastectomy, I try to treat IM node, but if the lung and heart dose become prohibitive factor, I skip it. I'm more likely to treat for women with central and inner quadrant disease for node positive disease, or if it's N2 disease, like 4 or more positive node. So if they have 4 or more positive node, or if they have inner quadrant disease, then I'm more likely to treat. But my threshold to drop is low if heart and lung dose are prohibited. Third is, how do you define inadequate dissection? There are no hard and fast rule, but there are two way I look at it. If somebody has more than 10 nodes taken out and more than half of them are positive. So in somebody with adequate dissection, meaning 10 or more taken out, but more than 50% are positive, then I define that as inadequate. Or somebody has less than 10 node taken out. So if somebody has inadequate dissection, I define 2 ways. Node positive disease with inadequate dissection is less than 10 nodes taken out. Or if somebody has more than 10 nodes taken out, then at least 50% nodes are positive. So half of the nodes are positive. The last question is, if Sentinel for biopsy positive and plan to treat post-mastectomy radiation therapy, do you include? Yes. So in somebody, if I'm planning to treat post-mastectomy for Sentinel for biopsy positive and has not had dissection done, like we talked about it, like 1 or 2 macromets, then I would treat level 1, level 2, level 3, supraclavicular, which is level 4 medial neck node, with and without upper IM node. So in somebody who did not have dissection done, which is, and to some extent, I would call that as inadequate dissection, I would routinely treat the axilla. But dissected axilla, we try to treat less just because of risk of lymphedema. Let me see if there is any other question.
Yeah, there is one more question that has come.
So I follow hypofractionation, and our dosimetry and early outcome data with hypofractionation for IM node was accepted at PRO, a practice of radiation oncology, just got accepted this week, and it will come out in about a month or so. In that series, we use hypofractionation for all regional node. Half had IM treated, other half did not have IM treated. As long as heart and lung dose constraints are met, I do not use fractionation as a reason not to treat IM node. Most important is making sure heart and lung dose are acceptable. And as I mentioned, we routinely use deep inspiration breath hold for both left-sided and right-sided breast cancer. And I would strongly encourage that, just because of the fact that it helps you reduce the lung dose also, which is important because you're treating these women for cure. And as you treat regional node, the lung dose goes up. In our series of IM nodal treatment, like the hypofractionation, our V20 was less than 25-26%. So it was not like 30-35%, but we did not see any significant incidence of pneumonitis. So that being said, in our own series with hypofractionation for regional node, the V20 for almost most people were like less than 26% or so. And I routinely treat it. I don't use that as a contraindication.
Thank you, Dr. Beriwal. I think that was our last question. And thank you for the insights into the Sentinel node axillary management, and then the questions also. So this brings us to the end of our webinar. I would like to thank our speakers for today, Dr. Beriwal, Dr. KITWADEE, and we have Dr. Tamaki, Dr. Shuzi, and Dr. Imjai from FARO on the panel right now. So if there are any last words from the FARO panel, Dr. Imjai, Dr. Tamaki, or Dr. Ozawa.
Nothing. Thank you for the speaker. That's all. I'm driving. Sorry.
No problem, Dr. Imjai. Dr. Tamaki.
Yes, I just would like to thank the speakers also, and also would like to thank the support of Varian, who's been our biggest supporter from the very beginning of FARO, and continue to use the experts from our region for the webinar of the company. And I think it really means a lot for us, and it means a lot for the development of radiotherapy in this region. And thank you, Varian, and thank you, Vishal.
Thank you, Dr. Tamaki. So I think we are good to close this webinar. Thank you, and have a great day ahead. Thank you. Bye-bye.
Thank you,
Thanks.
everyone. Bye.
Thank you.